What I'm going to do is, I suppose, give you a little tour at three levels, I felt. I understand my audience is very diverse here, very interdisciplinary, from masters, PhD students up to professors, practitioners and some theoreticians. So it's quite broad. Apologies if it's oversimplistic at times to people, but I prefer not to be too jargonistic if I can. I'm going to talk about a picture of health research as it is in Ireland at the moment, probably with a HRB bend, to, I suppose, give a status on the system, I suppose, in Ireland. I'd like to talk a little bit about particular funding instruments that we have, because I think there are probably people in the audience who are interested in applying for research funding, apropos of the introduction, and to talk about that a little bit. And thirdly and finally, a little bit of a conversation, and hopefully I'll tee up a few questions about where things are going. And I'm actually going to try and finish quickly because I'd prefer a bit of dialogue at the end if we can manage it. It's a big room, so I won't maybe do it during the course of the talk so much. It may be difficult to be heard. This is a slide I showed in Tallinn 1 month ago at a personal medicine conference, and it was really to give a bunch of Europeans, particularly East Europeans, a very quick flavour of the Irish healthcare system. Most of you will probably know most of this. If we spend 14 billion, that's about 9% of gross domestic product, 11% of gross national investment, if you like. That's pretty okay by international standards. It's up there with the UK and Germany and others in terms of the gross spend. I'm not talking about the outcomes, I'm talking about the investment. You'll know we have very much a mixed public-private model. Interesting compared to some of the systems we like to compare ourselves to, that we have 52 acute hospitals. That's 52 acute hospitals serving a population of about 4.5 million people. If you want to look at the comparison across the water, where we have about a population of 60 million, it's about 300 hospitals. So our ratio is quite different, and that's interesting in and of itself. And I'll come back to that later when we talk about hospital groups. You can see here the primary care situation, 2,500 GPs in about 1,500 practices doing 25 million consultations. Some information there from the HYPE system, outpatient and hospital discharges, etc. As somebody who's spent a number of years in the public sector system now through SFI and now in the Health Research Board, I would say, it's a personal opinion, but jobs was the primary political point, I think, on the agenda for the last few years. I think that's switching to health. The jobs thing hasn't gone away, but I think health is fast becoming the number one political issue. Right, research and development. Healthcare, most of us would accept, is a knowledge game, okay? It's clear internationally expectations and costs are rising well out of sync with the resources that we have to put into it. It's not sustainable. This is not arguable. So we need a much smarter use of those resources. There's nothing here I'd say you have not particularly heard before. I'll tell you now, this slide came from the West Northwest Hospital Groups conference a couple of weeks ago, where I was very strongly making the point, not least because the Director General of the Health Service Executive and a senior team were there. And I was advocating that our healthcare system needs a much stronger self-learning capacity. Okay, I don't think it's strong enough there today. And that's an ability to research and develop people, process and technology, both from within Ireland, but also the capacity to absorb that from abroad. I do not think that's strong enough in our system at the moment. And let me dangle something in front of you to say, should we be surprised about this? I'm going to show you 3 sets of figures, okay? Let's get a guesswork here. First figure will be the total spend of an organisation. The next figure will be the R&D spend within that organisation or system, and the third one then, if you express your R&D as a percentage of the total, you get what's known as an R&D intensity. It's a fancy term for how much you're putting into your research and development. Does anyone recognise those numbers? 14 billion, as I showed you in the first slide, is this Irish spend on healthcare. That's what we spend through our HSE and Department of Health. 43 million, as a matter of interest, is the budget of my organisation, the Health Research Board, the main health research funder. So in Ireland, if you look at the HRB spend and express it as a percentage of our total healthcare spend, you're talking 0.3%. Okay? Just the next set of figures, hint is in the currency. Okay? That's the NHS, 109 billion. If you take the budgets of the National Institutes of Health Research, the various councils in the UK, the Medical Research Council and so on, you're talking about a 2.4 billion investment in research and development annually. So in the UK, health research is getting about 2.2% of the annual health spend. So look at the comparison of those two figures. And then let's go a step further if we accept that healthcare is a knowledge industry. This is the figure, $53 billion, 2.8 and 5.28. Is that clear to people? Can you read that? Okay. They are the figures for one Intel corporation. Okay? A high intellectual property, knowledge intensive business that spends over 5% of its turnover on research and development. So as I was hammering the delegates at the West Northwest, that's just a pie chart showing the relative R&D spends there. The delegates of the West Northwest Hospital Group, which actually are pretty much all the hospital groups there. If we want healthcare to get smarter, which we have to do because things are just not sustainable at the moment, research needs to be substantially increased and mainstreamed into the care system, bluntly. So in a way that's a call for help or a plea for help on my part to the system. However, there are reasons to be cheerful. Let me talk about the Health Research Board briefly. Budget, funding, etc., as you see here. Probably not necessarily something most people tend to think of it as a funding agency. It has a funding agency sub-business, a very considerable part of it. But we also do a lot of evidence work for the Department of Health, and I would like to do more for the Health Service Executive. And these are in things like alcohol use, the food pyramid, fluoridation of the water supply is a big one underway at the moment. We manage 5 national databases in the area of drug use, disability and mental health, and probably well known to most of you here is the funding agency piece across clinical, population health and increasingly health services research. And that's right across infrastructure, people and projects. The evidence work and the information system stuff is effectively intramural. It's done by HRB staff, but it should be, I think, from what I know of the system here in the Midwest and the interests, and we might come back to this during the questions, there's a lot of data residing in these systems that might be of great interest to researchers and practitioners in this space. And I think that's something that can be looked at. And obviously the grant system works in competitive peer review here at extramural. I'll flip through these quickly. Unless you're on another planet, you will have noticed last June we launched a report on Irish drinking habits. This was commissioned by the Department of Health, and while anecdotally I think most people would accept in Ireland we drink too much and it's not healthy, etc., this is probably the first time we've put this stuff with serious data underneath, okay? And the conclusions of this study were that we drink too much. I don't think that's going to shock anyone, but the data was very interesting, not that we drink too much in this country, but the pattern we drink. We tend to consume it all on a Friday or Saturday night, and actually the concentration of that is even more harmful than the gross quantities that are consumed. And thirdly, and probably even more importantly, many of us don't realise it. I mean, when you self-classify whether your drinking is light, moderate or severe, many of us are effectively in denial. And why are we doing this? Because in fact the Department of Health is producing a public health alcohol bill. And without really good scientific data underpinning this stuff, we know the drinks industry is queuing up with an army of lawyers to attack it, okay? And it needs good scientific evidence sitting underneath it to make that happen. Just think of the tobacco industry and what happened with cigarettes. Okay, I'm not going to waste time on that. There's the 5 database systems. It's for everything from intellectual disability down to people who die from drugs and alcohol, to go back to my last comment. But if you're the HSE and you're planning services for physical disability, it could be people with multiple sclerosis where it's mild, profound or severe, and you want to plan your physiotherapy services or you want to plan your out-of-house services, that type of thing. You need to know how much of what is where. What's going on in North Kerry, what's going on in Waterford, what's going on in South Dublin. These are the information sources that help that planning to take place. But it's also a rich treasure trove of data for further research. I'm just hanging that one out there for people to think about. Raise your hand if you've heard of Cochrane reviews. Okay, people are familiar with it, all right? Right, we manage the Cochrane Library in effect and make it available to the country, and This does a number of things, but it's particularly in use for evidence for the clinical care programs. I think one of the talks earlier was quite interesting, talking about percutaneous. I think it was more in the, not in the stroke space, but this is one of these lovely reviews that a team we funded, I think it's Kevin O'Rourke and Peter Kelly's team, took 2 years to do this fantastic systematic review. And it's slightly symptomatic of our system, if I may say, because this fantastic review was done. It actually was first adopted, as far as I know, in Australia, then adopted in the UK, and now adopted here. But we're producing good stuff in the country, but I'm not always sure our absorptive capacity is as good as it should be. One of my favourite stories to talk about is again, could all those who've heard of ICORG raise their hands? Okay, so I need to explain this one. ICORG is basically an oncology network, a collaborative oncology that was set up in, I think, the 90s actually. But basically it does it's a network for clinical studies and clinical trials. And most of the oncologists in Ireland would be in this network. And in fact, you can see from the figures here, they're pumping through a large number of studies and trials, and in fact, have actually got early access to a lot of drugs for cancer patients in Ireland. It's a real success story. Not everybody knows, in fact, that it's underlain by a 50 million investment by the HRB over the past decade. One of the real stories, so that's me doing my PR bit. Let me tell you a real story. I love this because it combines real hardcore science, it combines with patient need and with economics, and they're three of the key ingredients for real transformative healthcare. This is a slide that ICOR gave me basically for a test known as Oncotype DX. I won't bore you with all the details, but this is a very fancy molecular test that will look for the expression of a combination of 21 genes in breast cancer. And basically, at the end of the day, all fanciness aside, will give you a score that predicts your likelihood of responsiveness to chemotherapy and your responsiveness to spread, or metastasis as it's called, of the cancer. And if you're over a certain score, once you've had your breast surgery, it'll tell you you are a candidate for chemotherapy or you are not. And the blue bars show all the people who are tested, the red bars show the patients receiving chemo on the basis of the test. So the gap between the two is all the people who were spared unnecessary, totally futile chemotherapy. Okay? So on the basis of this genomic technology, we have something that is saving people a lot of grief. Chemotherapy isn't fun. It's saving the system a hell of a lot of money. In these 8 hospitals that are listed here, in 1 year period, the saving directly was about 856k, and that's just for one slice. In fact, it was about 5 million over the course of a few years, as mentioned here. It's a fantastic demonstration of science, economics, and patient care, and the direction of travel for research. I couldn't resist putting this man up here, John Forbes, just to give a flavour of further research that we're funding. He is he's our first, I think, Research Leader Award, who works in the area of personalised health. So I've just given you the molecular genomic stuff. Right up at the other end, how do you take all of this stuff and assess its suitability for implementation, etc., in a real health system? It is entirely possible to come up with really fancy treatments and diagnosis and systems of prevention, but they can totally fall over, and this is the management consultant in me speaking, if you haven't got a capacity to really measure its effects and design realistic, implementable, reimbursable systems. Okay? I'm not going to go through all the details because I'm conscious of time. Sean Deneen, another one looking at the whole area of diabetes, but not sort of the drug molecular end, much more how patients, how much information patients need to comply with effectively to treat their own disease, maybe a better way of putting it. And he's done some really interesting stuff in that space. You can read the details afterwards. We're putting in place a lot of infrastructure here, specialist MRI scanners purely for research, available to researchers in the country. And many of you will know about Perinatal Ireland as an investment we've made over a number of years that culminated actually not too long ago in some very clear and excellent guidelines, national guidelines that have been adopted for to protect small babies in the womb, as it's referred to here. Okay. That's just a whistle-top tour of some real examples of good research that we're funding and is being done in this country. How am I doing? 20 minutes? Perfect. We're doing okay? Okay. Clinical research facilities. You may be aware of that this is the original vision. I'm not going to read through all of this, but we set out to establish some of these. And in fact, the HRB cannot take all the credit for this. Some of them, for example, in UCD and Royal College of Surgeons, Beaumont, pre-existed the HRB investments. Here's one in Galway, Clinical Research Facility Galway. That's the architect's drawing at the top. Underneath are 3 pictures I took only a few weeks ago. It's on target to be completed at the end of January. We have one in St. James that was co-funded with the Wellcome Trust. There's on Taoiseach looking down a microscope. And here's one in Cork with our former Minister, James Riley, former Minister for Health, the CRFC in Cork. The three that we have funded and opened. What I think is interesting, if you, let me check. All those who are familiar with the general thrust of the hospital groups raise their hand. Okay, mixed. Acute services are undergoing their biggest reorganisation basically in many a year in Ireland at the moment. 6 hospital groups plus a national paediatric. And these will have significant impact. This is known as the Higgins report basically for those in the know. At the moment, there's the 3 HRB facilities that we have built, and there's some 35 or 40 million gone into that. As I mentioned, there was a pre-existing one in Beaumont, RCSI, and in the Vincent's UCD group. And the academic partners are clear here. You'll notice who's missing from this, and I'm deliberately teeing this up. So those of you who are paying attention should be thinking about a question for the end here. Okay? I shall explain. Okay, but I will say this. It's nice to have physical buildings, clinical research facilities in place. But it's actually my view, I think they're necessary in some cases, but as time has moved on, we're actually seeing the greatest value is probably not the physical buildings themselves, but the processes and people that wrap around them. Okay? And that's where the greatest value comes in. I'm talking about research governance, quality and safety. And if you think of hospital groups developing where there are multiple hospitals and now there's 9 integrated care areas, how is that actually convened through a control point that can guarantee quality, safety, governance, etc.? So as I mentioned at the Trust conference a couple of weeks ago, the groups and the ideas they'll morph into trusts represent a fantastic opportunity, if you like, to centralise research within each region. As you know, I'm obsessed with trying to get research linked more tightly with care. I even suggested boldly to the group that research could be a criteria for the hospital group to transition, to trust transition. That didn't go down particularly well, actually. Okay, so that's kind of a general picture. Again, I don't know how many potential applicants and current HRB grant holders are in the audience here, but I understand there are some, and I think there might be an interest in knowing what's coming. I don't propose to go through all of this, but for those that want more detail, this slide deck is available afterwards, but there is also 2 webinars being run by the HRB to explain what calls are coming, what they're for, what the deadlines are, etc. One of them took place actually at 1 o'clock today, just 30 minutes long. A recording will be posted to the website, but the next one is at 1 o'clock on Monday week. Exactly the same, it's simply a rerun, okay? Designed to give people the information about what funding opportunities are out there, what the basic criteria are, what the deadlines are, that type of stuff. I'll pick on a few here. Skip that. Okay, probably the most important slide. If you want it on 1 page, these are the upcoming calls. If you're familiar with the calls already, you know the type of things they are. Some of certainly more senior people maybe. Health professional fellowships, you see the research leaders I mentioned earlier. This is when the call opens and when the call closes. Generally speaking, a call cycle is about a year. From the time it's launched, to the time it's submitted, to the time it's peer reviewed, to the time a grant is agreed with the PI and the host institution. There's some exceptions to that, but that's basically how it works. I think I'll go through 1 or 2 of these just to give a flavour, and then you can read through the rest if you're so inclined, or attend the webinar. I know this one has been of interest, I think, in this region. These are the health professional fellowships, so we're planning another call of this, with up to 7 awards in 2015. The details you can see are behind me. I think what's interesting about this one is the range of people that this applies to. It's very much targeted at practicing clinicians across all of these areas, okay? And So I'd encourage people to look strongly, both institutionally and individually, to look strongly at this. And you can see the contact within the HRB at the bottom here if you want to find out more. The interdisciplinary capacity enhancement awards, I'm not going to go through a lot of this stuff in detail. Research leaders I've talked about before. This is very important because we're talking about the top end of the spectrum. Unfortunately, we only have enough money for up to 3 of these, as I'm saying, because they're expensive. And they involve a huge recruitment drive with the host institution, etc. Because the idea is we'll fund these senior leaders, the likes of John Forbes I told you about earlier on, and that the university and hospital system will take over that post at the end of whatever it is, at the 3 or 5 year period. We're trying to change the structure of the system in effect and lend it this type of capacity. Probably the one, and I saw several of them referenced in the talks earlier on today, the mainstay of support is the Health Research Awards. These are basically the project grants. We call them the Health Research Awards, but they're effectively project grants. You're talking about your 330,000 over 3 to 4 years. And it's right across the patient-oriented, right up to the health services research spectrum, of which we are seeing more, and maybe we'll talk about more during Q&A. We also have what are referred to as definitive interventions flavour of this. And this is very much aimed at the kind of trial piece that we heard quite a bit about earlier on, to move beyond observational to more interventional work. Now, I'm not going to go through all this. It's really there for those who want to read detail afterwards. There is, as you know also, if you're at the biomedical end of the spectrum, we partner with Science Foundation Ireland and critically the Wellcome Trust to fund anybody who is successful in securing a Wellcome Trust grant. We basically outsource the peer review and everything to the Wellcome Trust, and then we pay 50% of the costs between ourselves and Science Foundation Ireland for those that are successful. Heretofore, it has not been a very used mechanism, quite frankly. I'm never entirely sure why, because I think the standard is here to be more successful at Wellcome Trust grants in certain schemes. I'm hoping it grows with time, and we have some stuff with the NIH in particular in the US. There are various supports available to researchers. For those that are actually thinking about design, trials, etc., we have the Methodology Research Network. We have those CRFs I've mentioned too, and there are various other infrastructural supports available. I don't propose going through all of that here. That really is a whistle-stop tour. I'm kind of conscious of keeping people from the awards ceremony. Okay, what are the next steps for the Health Research Board? Some of you will have heard that we are actually taking a very honest and frank look at ourselves at the moment. So I can tell you right now, we are in the middle of a first stage of a strategic review. And that's a fancy way of saying we're asking ourselves and getting outside independent people to test us. Did we do what we said we'd do in the Health Research Board? So a plan was launched in 2010 with various strategic objectives. And we have 10 international panellists coming from Australia, the UK and Canada to beat us up basically 2 weeks from now. Okay, and they've been asked effectively to answer 2 questions. To what extent have we implemented those objectives and how could it be improved? And there's kind of a third question in brackets, which is, do you want to give us any advice and recommendations for the next phase? Because a new plan is coming. And the idea is that should be operational towards the back end of next year. So we have a 3-day panel coming up November 10, 11 and 12. And interestingly, because someone asked me the question there during the coffee break, on the second day of that, for example, Tuesday the 11th, we have an entire day for external stakeholders, and Mary Shire, for example, is coming in from UL to speak to that panel, to give frank feedback from UL about how the HRB is operating, what it does well, and particularly what it does not so well and needs to change. It's a warts and all review, let's be frank. I've been in the system for quite a while. I spent 7 years at Science Foundation Ireland, right through the appalling recession that we're currently pulling out of. So let me make a few comments about things at a national level. Things that worry me. I think the national R&D system is somewhat dominated by the enterprise agenda. Jobs, jobs, jobs. You know, what research are you doing? How can you show that it links to a job? I think that's not good. I understand while we were heading for 500,000 unemployed, why there was a huge amount of attention on this, but it's not the right direction for the entire R&D system of a country. I think to some extent health research was somewhat submissive during this process and apologetic and tried to dress itself up in enterprise clothing sometimes. By enterprise I mean economic, okay? It didn't help that, for example, in SFI, when there was some change of tack, there was a huge amount of infighting by the research community. And what I think sometimes the research community didn't get was there were people outside the research community, read the Department of Public Expenditure, who were only too happy to see this fighting going on, suggested, well, we'll give it to agriculture, they'll put it to more use, or we'll give it to primary schools, or we'll give it to, you know. So we, as a community, need to get our act together, quite frankly. I'll come to that in a moment. And I'm talking about research in its broadest sense here, right across the spectrum, but particularly health. And there is a stubborn gap between health research and health practice, and that means actually, there's no rocket science here, but translating the findings and actually being able to prove it and to show to the people who allocate the funding to us to do the work we do that it's worthwhile and it actually translates into improved health care. And we haven't, I think, been particularly good at that. And I think that goes for everyone in this audience, but it also goes for the HRB, quite frankly. So I want us to stop the infighting. I'm quite candid and blunt about this. And the health research community needs to unite and be more coherent and constructive in its presentation to the wider system in Ireland, the ultimate funders from government, etc. I think we need to reposition our community within the national system and get better at articulating the value we give, okay? And do more to bridge that research to practice gap. Maybe there might be some comments or views on that during the Q&A. It's long been my concern, and I'm going to leave this kind of thought hanging, that in the view of Department of Finance, Department of Public Expenditure, let's just say national government level funding, that research in some countries, particularly more immature countries with regard to funding like Ireland, that research is a kind of I'm using my management consultant speak here, is a cost centre. It's something that costs and it's perceived that way, as opposed to being the antecedent for something that is really good, service reconfiguration, improved healthcare. How are we going to stop our investment in healthcare heading towards the US? 17% of gross domestic product in the US being spent on healthcare. It's completely unsustainable. We have to move from this cost centre to the value articulator, enterprise speak, to use that, to a profit centre type paradigm, okay? This is what we need to do, and it requires a kind of a shift in mindset of us all, quite frankly. So I think I shall leave it there provocatively. Thank you.